Check. Check. I think we can go ahead and start.
Is it working?
Get started.
Greetings.
Go
I
ahead and
think
get
we'll start. I do want to mention that this is all going to be video streamed so that the folks that aren't here will be able to watch it. So welcome to everybody. This is really Diane's show that we do, and Sue Yen's show. But so I'd just like to make a couple of comments myself. I actually love the student panels because as long as I've done this, I always learn a ton myself from listening to what the students have to say about the different sites. Dr. Pedrino, who's now the Dean for Clinical Curriculum, asked me to make these comments for you. She's the person that you're going to work with. She replaced Dr. Dan Wolpaw in terms of all your rotations and issues. And she said, there's one message and one housekeeping detail I'd like to ask you to convey. The more important message that the location of cores is not the most important factor in getting good letters of recommendation or mentoring. There's a lot of opportunities for that in the AIs and electives, so you try not to get too attached to a particular rotation. The other item has to do with what's called non-block, and I think Sue Yen is going to concentrate on that. It looked like it was erroneously put as vacation, but it's really non-block, and Sue Yen will clear that up. I totally agree with Dr. Pedrino. We've been doing these for a long time, and my view is all the sites are good, and as long as I've done these, I can never remember somebody coming to me in the fourth year and saying, gee, if only I'd done a rotation at site X, I would be better, or somebody saying that after the match. Really, it all works out. There's nobody in the country that has better choice of hospitals than we do if you put UH and the clinic and Metro and the VA together, so there's fantastic teaching at all the sites. I do want to make one comment about grading because that's something that we hear from the students on a regular basis. All the clerkships have the same breakdown, which is 75% of the grade is based on your clinical performance, and 25% is based on the shelf exam. And all the different clerkships do it a little bit differently in how they weigh it and what they weigh it, but I do want you to know that. So and that, I think the person that's probably going to be the most important to you and the rest of your career is the registrar. So here's Sue Yen to give you some of the nitty-gritty.
Hi, everybody. Welcome. I just want to make a few comments and remarks. So I'll probably take about 10 or 15 minutes. So I wanted to welcome you guys again. I know you're in clinical immersion, and the SEQ on Monday is on your mind. And also, I know that this meeting is really organized by Guyan. So please join me in an applause for Guyan. And also, let's wish our seniors up here good luck for match week next week. It's a great panel, and which everyone is invited to, and it's a great panel that they have up here. Before we get into the student panel, I just want to take a few minutes for announcements and reminders. So I have to move. Oh, Guyan, I'm sorry. I have to move your PowerPoint for a really quick second. No, you're good. You don't have to move it out of the way. I'm just trying to find the browser on this. Oh, it's IE. So what I'm going to do is I'm going to review really quickly where our policies for the core clerkships are located on the Curricular Affairs website. I just wanted to remind you that you are all responsible for this information. I'm not going to go into detail about it, but I'm going to show you where you can find it. I want you also to know that Carol Chalkley, whose office is across from E401, across the mailboxes, but next to the drinking fountain, is pretty much going to be emailing you reminders throughout the year about those policies. During this core clerkship year that you have, please know that you can always contact your society dean or myself if you have any concerns about anything at all. And if you don't feel comfortable talking to your societies or you can't reach me or whatever the reason, please consider Carol Chalkley your safe contact person. I am going to be working with Dr. Pedrino. She will be working with Dr. Pedrino on your orientation for your core clerkships, which will start on the first day of your basic course. So keep an eye out for emails from her. And just to elaborate on Dr. Smith's comment about in e-curriculum, when you look at Block 6, it was just updated recently. So there was a question from one of your peers that in Block 6 in e-curriculum, there was 2 extra weeks at the end of like the left-hand side where all the weeks are listed. It was showing up as vacation, and it's not vacation. You should all know that you should be concentrating on some variation of research and scholarship for your research project or board study. That was just a clarification. So the Curricular Affairs website, really quickly. I'm just going to navigate there really quickly, if I can. Oh, here we go. So the Curricular Affairs website, I want to point you to this link here, Basic Core Rotations and IQ Plus Sessions. So there's a lot of information here. The first thing I wanted to point to you was here, Clinical Rotation and Policies. So there's core objectives at the top, but down here there's absence request form and instruction sheet using the clinical assessment system CAS, which we'll go into more detail in your orientation. But if you want to look at it here before that, this is really good information. The clerkship absence policy, harassment policy. The AI guidelines are more for your 4th year, but you're welcome to look at that. The vacation policy, the MBA and shelf exam schedule, how that's sort of set up for your core clerkships. And there's a handout going around as well that's printed out copied from your student handbook about how core clerkship grading is done. We get a lot of questions about that, so please review that. Okay, so for choosing your clerkship sites, you go to Basic Core Clinical Rotations. And under Basic Core Presentation Information, this is the information that the clerkship directors provided us in 2012 when the new iteration of the clinical curriculum started. And as you all know, we don't have Kaiser, so disregard that. But there will be PowerPoints here about the rotation for each of the sites, and you can take a look at that. There's contact information. There's a nice little grid about how many students can fit there, and some of that will change, but essentially this is how all the students will kind of rotate throughout the rotation. So take a look at that. These really vary across sites. Some are really integrated, some are not. And it's up to you what you want to pick. I know there's going to be a lot of questions about it. To summarize, in the end, if you don't get the location that you want, you can do AIs or electives at that location. You can ask your panel some questions about how to make that decision. So basically, these PowerPoints are here for you to review. I wanted to make a few remarks about the core clerkship scheduling. First of all, I really want to thank every single student in the class of 215 for their patience with this process. Student names were blinded in the process. No students were singled out at all. I want everyone to understand that. Every effort is made to accommodate preferences, but I can't guarantee that. There is room for everyone to finish their basic course, but we're not able to always meet everyone's first preferences. Some changes that we had recently, and I'm getting some questions about this. We were not able to accommodate as many B1s, any folks from the B category as we thought we would. I don't know if you remember, but this wonderful multicolored spreadsheet in the B category. And when you went into the lottery and you saw these numbers with the capacity on the far right-hand side, we weren't really able to accommodate all the Bs due to some changes with course 1 and 2. Those are really big challenges right now. So we had to have some students start with surgery. And there weren't very many students that wanted to start with surgery. So if you picked like something that started with core 3, I gave I had to have some students move to the same group, but with surgery first, and it's just a flip of core 3 and 4. I know I'm getting some emails and comments about this, so I'm trying to work with everyone as much as possible. There's a lot of flexibility still to do direct switches throughout the year. This process doesn't end. I just want everyone to keep in mind that I cannot make switches less than 45 days before the start of a rotation. So throughout the year, you can add, drop, you know, you can switch direct switches up at, 45 days before the start of rotation. So I sent an email to the class about the timeline for what I'm working with, and I'm following that, but I'm still working on, fine-tuning things and trying to get the numbers right. So capacity is a really big issue, just to make sure that we can all, move the class through the curriculum. Dr. Brugino will probably give more information later on about new experiences that we have, new capacity information to accommodate cores 1 and 2 numbers. Let me see, I'm just going through my notes here. If you have any questions at all, feel free, besides myself, Dr. Pedrino and your society are available to help you answer questions and think through things. Another question that we get is when you're doing your site scheduling and you want, for example, you're at UHV and you want more information about that site and you want a particular preference for that rotation, I send the rosters to the sites 45 days, again, before the rotation starts. The coordinators will be contacting you about 30 days before the start of the rotation to ask for your preferences. For example, like UHVA, they'll ask, if you want, this track at UHV, and that's when you can tell them that. So make sure you read your emails, respond to your emails. That's really essentially what I have. I'm always available. I think I've caught up on all my emails and answered pretty much everybody. So if I forgot, please let me know. If there's anything else, just let us know. Stop by, give us a call, email me. Give me a little bit of time to respond by emails. I think essentially that's it. And the student panel is here to take over the rest of the time. Again, I'm available for questions, comments, and I probably have a few minutes right away if anybody has any questions. Okay, so thank you very much. I think I'm going to hand off the torch to...
Sure, so thank you everyone for coming. I'd like to thank the panel for the short notice. And it's a mix of third years and fourth years here. So I'll just have everyone introduce themselves. If you want to say where you did your rotations and also what you're going into.
Hi, I'm Sarah Sweeney, and I'm planning on going into family medicine. I did my surgery and medicine rotations at Metro Hospital. Well, actually, I pretty much did all of my rotations at Metro Hospital except for neuro and psych. I did psych at the VA, and I did neuro at UH.
My name's Ellen Martino. I'm going into OBGYN. I did surgery and medicine at the Cleveland Clinic. I did psych and neuro at Metro, and I did family medicine, OB, and peds at UH. And that's it.
You want to go back?
Hi, I'm Michelle. I'm a third year. I'm currently at Metro for OBGYN and peds, and I did surgery at UH, and I guess EM too. And then I did neuropsych at Metro.
Hi, I'm Aaron. I'm a fourth year. At CCF, I did medicine and surgery, and then I did the remainder of my rotation, psych, neuro, family medicine, OBGYN, and peds at Metro.
Miles. I'm also a fourth year, going into internal medicine. I want to do hem-onc down the road. I did medicine and surgery at UH and everything else at Metro, including emergency medicine.
I'm Kyle. I'm a fourth year. I already matched in urology here at Case. Yeah. Oh, thanks. So, if you do surgery somewhere besides CCF, you might see me. I did surgery and medicine at Metro. I did neuro and psych at CCF, which I think is my semi-unique one. And I did OBGYN and peds at UH and did family medicine at the free clinic.
My name is Ron. I started with surgery and emergency med at Metro, and then I did psych at VA and neuro at UH, and now I'm doing family medicine and internal medicine at UH VA, and I'm doing internal medicine at VA right now.
I'm James. I'm a third year. I started out my rotations with neurology at the VA, psych at UH, and then I did surgery and emergency medicine at the Cleveland Clinic, and right now I'm doing peds and OB-GYN here at UH.
My name's Stephanie. I'm a third year. I'm going to do pediatrics. So I did everything here at UH except for medicine and family med, which I did at Metro.
I'm Mike. I'm a third year. I'm also going into pediatrics, and I also did everything at UH except for medicine and family, which I did at Metro.
My name is Patrick. I'm going into surgery. I'm a fourth year. I did everything at the Cleveland Clinic aside from psych, neuro, and emergency medicine at UH, VA.
Hi, I'm Clarissa. I am a fourth year and I'm going into pediatrics. So I did neuro and psych at CCF. I did medicine and surgery at Metro, and then I did family, OB-GYN, peds, and also peds ED at UH.
Hi, I'm Emily. I'm going into emergency medicine, and I did everything at Metro except for Core 2, which was OB, peds, and family, which I did at UH.
Hi, I'm Jamie. I'm a fourth year going into peds. I did medicine and surgery at the VA, family, OB, and peds at UH, and neuro and psych at Metro.
Alrighty, so this panel is supposed to be to help you get an idea of the pros and maybe cons of each rotation. As Dr. Smith has also already pointed out, every rotation and every clerkship site is going to give you an excellent experience. So please, take everything that people say with a grain of salt. They are just opinions, after all. But legitimate opinions, because these are people who have gone through it before. So just ignore what I just said, actually. Also, if you have questions about step one, because I know none of you really care about that's coming up, please feel free to ask. Do not ask people what their score was, because no one's going to tell you. If you have general questions, please feel free to direct it at anyone, and I'm sure that they'll all have varying levels of advice and things that work for them. But we'll try to hold off on that until the end, otherwise it's just going to be an avalanche of those kind of questions. So who has a question regarding clerkships? No one. Excellent. Okay, yes, please go ahead.
For the person, I forgot who already started.
That's all right.
Who did peds ED at UH? Sorry. Was that part of the normal emergency medicine rotation, or was that part of the...
Repeat the question, Clarissa.
So the question was, I mentioned that I did peds ED at UH, and the question was that a core rotation during third year, or was that something separate? And so I'm currently a fourth year, so our schedule was a little bit different than what you guys will have coming up. And so for me, it was one of my AIs as a fourth year. So I don't know if it's offered, and it looks like the third years are saying no. So look out for it as a fourth year, because it was really fun.
Any other questions? Yes, Siavash.
I'm interested to hear if there was one thing that you would, looking back, would be like, do not do this. What is that? One thing where you would, if you had the opportunity, you wouldn't do that again. What should I watch out for? So I guess a couple things I can give you.
Are you speaking from experience?
Well, and experiences of friends, shared experiences.
Repeat the question.
So looking back, what would you do differently, whether mistakes or even if they weren't mistakes? First is if you're on the fence about something, which is usually people who are thinking surgery or not, I would recommend not saving it till the very end, because before you do surgery, you'll be scheduling your surgery AIs, and those are kind of non-refundable. So then you might get into your surgery core, not want to do surgery, and be stuck with the next 2 months of just horrendous AIs with no energy to do different AIs after. So I've seen that happen to people. What happened to me personally is just scheduling of research. I did it kind of early. And if you're wanting to do AIs kind of early or do more AIs or not sure of what you're wanting to do, I would recommend putting your research blocks later on, and then you could maybe do some electives during that time while you're doing research. So you have more flexibility once you've kind of decided this is what I want to do or these are the things I'm interested in. So for me, I started with research, but you can't sign up for electives if you haven't done some of your cores. So it's kind of tough. So think about that. Like if you want to do like an ortho elective, you might want to do surgery first, and you may want to do that elective in like February of next year. So just think about your research time, and don't think of it as this has to be research. Think of this as this could be electives. You can look online at the elective schedule and see what the prereqs are. Sometimes it's like just have done core 1 and core 2 first. So think about that and try to make a 2-year schedule and not a 1-year schedule would be my recommendation.
Any other? Yeah, go ahead, Michelle.
It's not really something I would do differently, but I would say if you're interested in emergency medicine at all, like really try to go to Metro, or at least do an elective there. I did mine at UH, and I know some people who are kind of on the fence, and unfortunately it seemed like they jumped off the fence after doing it at UH. It's just not as, it's just a very different setting. So just like be aware of that. It's not like a super negative thing. I had a good experience, but it's just very different, I think, than like a trauma emergency room. But like Ron was saying, you can take your research time and do an elective or just go there for a couple weeks or something too, to Metro.
Yeah, I never rotated at UH, so I actually don't have anything to say about that, other than Metro is a phenomenal place to do emergency. And I do have something that, not that I wouldn't do again, but that I would recommend. Stay the hell off your cell phone during rotations. You can be looking up the most valiant, intelligent thing in the universe, and you will look like you're texting your friends. And I've seen attendings and residents roll their eyes at students, so just don't do it. Just don't do it. Write down stuff to look up later, or very obviously say, I wonder what Hippocrates says, and look it up that way. But otherwise, just keep it off.
Thank you.
One thing that I did was that I kind of blew off shelf exams for my first rotation, which I feel like I got kind of bad advice saying like they don't really matter that much. Like it's all your clinical grade that makes up the majority of it. But I definitely got burned at least once by not doing as well on the shelf exam as I could have, and definitely could have got honors by doing that. So don't blow those off. And then I don't know because your schedule's a little shorter now, but we always had multiple electives with each rotation, and feel free to kind of like push the boundaries of what you can do for those electives. Like during pediatrics, I specifically requested to do pediatric urology, which is like within the surgery world, like not even really pediatrics, and they let me do that, and that was really helpful to do at the beginning of my year to kind of get to know the residents in the field I was interested in going into and get to know the field a little bit better. So I would suggest trying to do something like that if you can.
Yeah, please go ahead.
We're not actually worried about this yet because we're not in clinicals yet, but I've heard mixed things about the shelf. Some people say they actually studied, and some people said you don't have time to study, and like whatever you did in the rotation should be enough. But
No.
No. So how much do you guys actually study for this shelf?
A lot. So I mean, I think that probably most of us at one point or other have gotten the piece of advice that, oh, there's this like gray area. As long as you score in this gray area, like if you get clinical honors, it won't affect your grade. It's a bunch of hogwash. If you don't get a high grade on your shelf exam, I can almost 100% guarantee you will not get honors on the rotation. Like 75%, 25%, like being the type A personality that I am, I've done all the math for every single percentage from 100% down to 90% for the clinical grade. And I can tell you it doesn't quite compute that way. So study hard for it. So to follow up your question, does anyone have any advice on how they would study for the shelf exam while you're rotating? Stephanie Kabler, since you raised your hand.
I got one.
Or Miles, go ahead.
I got one. So I guess I have advice for medicine because that was the only one that I found that I feel like I prepared well for. And not because I didn't try to prepare well, I just didn't hit the mark well on everything else.
That's not true.
If that makes sense.
That's not true.
So for medicine, I found that the MixApp question set was really helpful. And if you do that if you do your medicine rotation at UH or the VA, they actually give you a copy of that if you want it. I thought that those MixApp questions were so very close to what the shelf exam questions were like that it made the medicine shelf exam very easy for me. And I'll take that with a grain of salt because I'm going into medicine and I found medicine to be exciting and fun. But for the rest of the shelves, I didn't find one resource that was like my go-to. It was kind of a collection of different things, including like a smattering of books, including like case files and like NMS surgery case book and you name it, pretest.
You read it.
I read it, and it didn't really work well for me.
That's a lot.
Yeah, I would have to agree with Miles that questions are probably the best way to go, but the hard part is like finding questions that will reflect the shelf exam, and you guys will become really familiar with UWorld in the next few months, I'm sure, as you take step 1. But UWorld step 2 has actually been kind of my crutch for all of my studying for shelf exams, and given that I've only taken, I don't know, I still have 3 more, I have 1 tomorrow, but I still have 3 more exams, so I can't attest to those, which are neuropsych and surgery, but I can attest for the other ones that I did almost every UWorld step 2 question for each section, and medicine has about like 1,300, and that was very helpful. Peds has, you know, a good amount, but some of the other ones don't have as much, but I think in the end that the UWorld questions also kind of reflected the shelf exams well, and in the end it'll like serve you well for step 2, hopefully.
So I have something in particular to say about that. Having just taken the psychiatry shelf today, the UWorld questions don't necessarily reflect the full scope of the psychiatry exam. So you know, with some of the specialties, you need to remember that, you know, it's both an adult and a pediatric kind of scope to those exams. So especially in psychiatry, there was a lot of pediatric psych. There's a lot of, you know, developmental disorders, things like that, that isn't necessarily covered by the UWorld questions because they're not as well covered by step 2. So just keep that in mind, that the shelf is a different exam than step 2, obviously.
You guys will receive a PDF document that's a couple of years old, but there will be some changes to it that it was a research project outlining what were the most helpful, what's the word I'm looking for? Sources, thank you, resources, to study for the shelf exam.
I would just say to start being aware also of like this rush to buy a lot of resources to pay for it. Like there's a lot of costs coming up in your 3rd year with trying to have resources for all of your clerkships, and then in your 4th year with, you know, more boards and traveling, it really adds up. So I think my advice would be that, you know, for the shelf exams, it's not about like having the perfect book. It really is the same way you're going to have to sort of like study for the step 1s and learn the little specific details that they ask in these type of, you know, standardized exams. But I would just like suggest be careful not to necessarily like think you have to buy a UWorld account for your 3rd year in order to be able to do well on these clerkship exams.
In terms of finding time throughout the rotation to study, you really have to be efficient with and being pretty self-disciplined with taking time out for at least 2 to 3 times a week, especially if you set up that pattern towards the beginning of the rotation. Maybe the first 2 weeks it's of an 8 or 12 week rotation. You're trying to get used to that rotation. So maybe studying for the shelf exam that far out is not that high of a priority. But getting in the habit of spending, you know, even if it's you know, a 45-minute study session to go over 10 questions and then their subsequent answers can get you in the habit of early on starting to chip away. It's kind of like a chipper kind of thing. You just chip away at it a little by little. Then by the time towards the end of the block or the end of the rotation, you'll have had seen a lot of stuff that can help you on the wards, but then it helps you prepare for the shelf towards the end of the rotation.
And also, when you're budgeting your time, make sure that you're really taking into account the kinds of things that you're seeing at your clinical site versus the kinds of things that are going to be covered on the exam. So for me, I did medicine at the VA, and I absolutely loved the VA, and I have no regrets about doing medicine there, and it was a fabulous learning experience. That being said, did I see any patients that were younger than 55 or 60? Not really. Did I see any female patients? 1 or 2. So there are things that I really didn't get from day-to-day experience in the wards that I really had to carve out time to study. And if I didn't do that, then I really didn't get it. So like breasts, I really don't know much of anything about them. And you know, that's not really a good thing. And I wish that I had studied that more So, you really should pay attention to sort of the strengths of your site and the weaknesses and make sure that you're sort of supplementing those weaknesses.
I think going along with what Jamie was saying, like pediatrics, I think is an excellent example. Like you just won't see the things that they test you on. Like even at Rainbow, like you'll see awesome, amazing things, but like they're gonna test you on things that never came up. And then going along with what Sarah was saying, like I didn't buy a single book during third year because all your friends are in different rotations. So every rotation I had friends who had those books. So that was my strategy for saving money.
Okay, very good. Another question, please? Oh, I saw like 4 hands.
What's the process of applying for AIs? Is some AIs competitive?
Sure. Anyone like to speak to that?
Sure, I'll speak to that. So OBGYN was really popular in our class, and so it was kind of tough to get AIs where you wanted them or when you wanted them. So someone already mentioned that it was really nice to have research at the end of the year. That was huge for me. I had my whole research block at the end and was able to get into a really popular OB AI only because of that. And it was full till like February. So certainly no chance to get on your application and maybe not even time for it in the whole year if I hadn't have had that time. So I definitely think you want to be thinking about where you want to do your AIs by January. And then in terms of whether you had to write an essay or anything, for not for OB, but for I think emergency medicine and a couple other ones you did.
Just to reiterate, the question was the process of how do you go about scheduling your AIs, and if this is for the recording, not for you guys, because I know you can hear it, and if there is a certain process that's in place.
I mean, did you apply? I think Ron did. Yeah.
Sure.
Yeah. So countrywide is a completely different story, or a more complicated story anyway. But at least if anybody here is interested in emergency, the place that you're going to want to do it is obviously Metro. And to get into it, of course, everybody wants to do it at Metro, and there's a limited number of months. So unfortunately, Dr. Duslan has had to make it. You have to apply. So they do kind of go on your numbers a little bit, and you do have to submit an essay about why you want to do emergency and why you want to do it there. My best advice, I would think, would be to make contact with the department, to shadow a little bit. I know if going into your third year that might be difficult, but if you have time during your research block, certainly do research there. And if you're a known entity, I think your chances will be a little bit, I don't want to say better, but it will be easier for you to get that process if they already know that you're interested long term, that kind of thing.
Can anyone speak to scheduling? We'll just do it by specialty since this is a topic. Surgery AIs?
So I did a surgery AI at university hospitals, and the process for signing up for that was, I think, around this time. So in your third year, around January, February, March, is when you want to kind of start thinking about it. And to sign up for an AI in Cleveland for surgery, general surgery, it's more or less just emailing the coordinator and asking for a month that you're interested in, or asking what's available. And it's sort of first come, first serve. So if it's anything that might be, so it's not so much, in my experience, whether or not you'll get an AI, it's when you'll get the AI. And the sooner in your fourth year, the better in terms of gathering letters and having it show up on your transcript. So if you want the ideal month sort of June, July, August, and maybe September, you want to kind of ask earlier, around February or March. And it's really a process of just finding out who the coordinator is and emailing them. And then I believe notifying the registrar subsequently.
I neglected to mention that I'm going into ortho, so another surgical. Don't shake your head at me. I'll come over there and put you in traction. No. Okay. So the process for that was very similar to general surgery. I did a rotation at UH and Cleveland Clinic, and it was basically around this time-ish. You email and see what times they have available, and then it's what time you get rather than having a spot. I think they kind of save spots for us because we're kind of home program people. As far as doing an away, I did an away at Michigan, and that was through VSAS. I got dinged a little bit, so I didn't apply I didn't have the opportunity to apply as early as I could have, or should have, so I had to rotate a little bit later. But yeah, as a part of that, I mean, each place is a little bit different in terms of application, and usually they ask you, why do you want to rotate here? And so you got to have a reason.
And that's more specifically for aways than
Yeah,
like your home
yeah.
institutions.
So yeah, not UH, not Cleveland Clinic, not Metro. That's specifically away rotations.
So one of the purposes of doing an AI is so that you can get a strong letter of recommendation in your chosen specialty for your residency application. So going off of that, you can start to think about building strong clinical mentors throughout your third year. Because I think some people sort of had to think back about who might write a recommendation. So if you're planning on going into something, it's not all going to be based on where you do your AI and the letter you get from them. Because to be quite honest, sometimes you might not even have a great experience in your AI where you're going to get a great letter. So I would suggest like trying to build some of those relationships, whether they're with a research mentor this year or whether through some other way to sort of within your chosen specialty have a strong clinical mentor to write you a really strong letter.
Can someone speak to about medicine or pediatrics a little bit too? Miles, go ahead, please.
So medicine, I did 2 AIs at UH. So medicine AIs in general, there's a lot of spots for them. But if you understand like the AI requirements, you have to do one of your 2 AIs in medicine or surgery. So there are a lot of people that don't want to do medicine that have to do a medicine AI. So the spots are a little more limited with that in mind. So, you know, like I think Clarissa said, there's kind of a period where you really want to do, or was it Patrick? Patrick said
they look so similar.
They do, you know. I just always get them confused. I'm sorry, guys. So the period between like July and September is kind of like prime time for AIs and getting letters of recommendation in. So those periods, you generally want to ask kind of earlier if you want to do a medicine AI during those periods. If you want to do a medicine AI throughout the rest of the year, I don't think there's really, like you could probably sign up for a medicine AI for like next week, like if you wanted to. But that kind of prime time real estate is something that you want to ask again earlier, like in this time of year next year. And I don't know if one site is kind of more in use than any other for the AIs. I found UH to be very, very helpful. If you apply to medicine, you need a committee letter or like a chair's letter, and Dr. Armitage and Dr. Walsh write that for anyone who rotates at UH, and they are excellent. I've gotten a lot of compliments on the letter from them, so they're great people to have on your side, and they're great resources. Yeah. And you can, so one thing that's not listed as an AI also is critical care. So anything in the medical ICU, but you can actually do those as AIs, and I would really recommend that.
Kyle, can you speak about urology? Because I think
I can.
it's a little special. And then we'll do pediatrics.
Yeah, first thing is that I did a medicine AI back in January, because if you have to do one, but you're not going into that, I suggest like putting it off, but not beyond that point, because you're going to stop caring after you like get around the end of the year. And it's a good experience. So, but for urology, it's early match, so that mattered a lot. I finished cores in June, and then I had July and August to do both my AIs because interviews were going out at the end of September, and there was no time to get a third institution's letter of recommendations or anything in before that point. So luckily, we actually had 8 of us go into urology this year, which is a high number, but there's going to be spots for you at UH and CCF in those 2 months. So you won't probably, just in terms of when you want to do them, either like UH first or second, that might be a problem, but you won't have a problem getting those. But if you do want to do an away rotation, you'll have to, it's kind of tricky scheduling those in urology at least, because your letters in urology have to be from urologists. They don't care about anything else. And if you try to schedule an away rotation at multiple places and then cancel on some of them after you choose which one you get into, those places won't interview you. So don't like schedule an away rotation AI and then cancel it. Like do it like stepwise. Like ask a place, like wait a couple of days. If they don't reply to you, like go to the next place. Don't send out like 10 emails trying to get away rotations and then drop them later on. So.
And we'll just wrap up with peds here.
Yeah, for peds, it's actually I think is the nicest way to do it, which isn't first come, first serve. It's literally, there's a deadline that you submit your application, which really isn't an application. It's just preferencing what month you want to do it and what team you want to do it on. This is for Rainbow, which I think is will serve you well to do your PEDS AI at Rainbow if that's what you're interested in. And then there's just a deadline. Dr. Dell, the clerkship director, just goes through. His kids pick out of a hat, and then you get an email the next week saying do you want to accept this offer for your AI? So in the end, you don't have to think too much ahead about it. You'll get an email from I don't know if it's Suyan or Yuna or someone. We'll send you an email out, and then you'll just sign up from there.
Clarissa, is there anything you want to add to that?
Yeah, sure.
One thing I will say for PEDS is that Dr. Dell, when he does this whole process that Steph just talked about, it happens in February. And I didn't do my PEDS rotation until March, and I didn't decide on PEDS until April, but I went ahead and signed up. That being said, my roommate who ended up going into ENT got stuck with her AI, so it's just tricky. Just whatever you sign up for, make sure you know when the drop date is. Just kind of know, because that'll be specific to each one. If you don't get a PEDS AI, or a PEDS floor AI at Rainbow, which can happen, you can do a NICU AI, you can do a PICU AI, get wonderful letters from there. One of my good friends did a 2-week ID elective at Metro, so if you don't get your dream schedule, it's totally fine, and you can get letters lots of different ways. So whatever you get will be fine.
All right, let's go ahead and, yeah, please go ahead. So the question was, for PEDS, do you only have to do PEDS AIs, or do you also have to do a medicine and surgery AI, I assume is what you're asking? Clarissa or Jamie?
I'll answer.
Mike?
I'm also going into pediatrics. Thank you.
I'm sorry. I forgot you were there. I just blacked you out.
You can be a tall guy and go into pediatrics. No, so it's my understanding that you do have to do one of your AIs in medicine or surgery. Is that correct? No. Oh, you can just do PEDS.
Medicine, surgery, family medicine, or PEDS.
Okay, well there you go. So you can just do PEDS if you want. So you can do a rainbow floor, and then also PICU or NICU if you want. Or do family medicine. You see lots of kids in family medicine too. So whatever floats your boat.
Go ahead.
So can I talk about the family medicine AI real quick?
Absolutely not. Yeah, please. Go
Yeah,
ahead.
so my wife is going into family medicine, and Sarah might be able to add to this too, but I know that when Sarah, my wife, was applying for the different AIs, she was actually having issues getting any AIs other than UH. Apparently CCF and Metro don't offer their family medicine AIs very regularly. I don't know if you had this experience, Sarah, but so if you do want to do a family medicine AI, just take that into consideration. You might have to do a little more kind of legwork to do it in any place other than UH.
Yeah, since you brought it up, I'll just make a quick comment related to that, and just kind of related to if you're planning on going into family medicine or you're even considering it, or planning on going into a more primary care-based specialty through medicine and pediatrics. I think you're right there. We have not very many people out of any of our classes that really go into family medicine, so I think if your UH consistently offers their acting internship and their rotations, but I think if you're interested in that, you maybe could reach out a little bit earlier to Cleveland Clinic, which is at Fairview Hospital, which is a great community hospital, or Metro Hospital, and they both have family medicine inpatient services. But related to that, your third year is very, very inpatient medicine based. So if you are really interested in doing family medicine or something else which is going to have a really strong ambulatory component and continuity based care, I would suggest thinking about that as you begin planning for your fourth year, because you really aren't going to get you're not going to get an experience in the broad range of primary care practice during your third year. So I ended up in my fourth year sort of creating my own elective, which was 4 weeks at a community health center here in town, working with family doctors, sort of doing their more day-to-day outpatient practice. So that's just something to think about if you're thinking about going into primary care.
Go ahead. Yeah, please.
Can you guys talk about your pros and cons of the location you did a surgery rotation at, Metro versus UH?
So the question was specifically the pros and cons of the various sites for your general surgery clerkship. Go ahead, Michelle.
So I did mine at UH, and I guess now with the new schedule, because I guess they did medicine and surgery together, and we also have emergency medicine with surgery. So at UH, there's 2 weeks of ED exclusively. 4 weeks of a general surgery service. You have to do 1 week of anesthesia, which only leaves 1 week for elective, which for me wasn't a huge problem because I was between general surgery and OBGYN like in my head, so I didn't really care. But if you're kind of thinking of doing a surgical subspecialty, I would kind of keep that in mind. With that said, I had a great experience. I think my hours, although like difficult, weren't nearly as demanding as some people at Metro. They take trauma call. I mean, I think people here, they can speak to that. But I had a great experience, so don't let that sway you. But that's just something to keep in mind, that you don't have as much elective time the way the schedule is now. But again, like, you can use your research time, set something up on the side, and a lot of people have done that to kind of, you know.
And who's done surgery at Metro?
So I was 2 years ago, so I don't know if this is different now, but at Metro was really nice in that they had 2 one-week electives, I believe, or 2 two-week electives. Anyway, I got to do 2 electives, which was nice. I got to do urology, which I wanted to do, and I got to do like acute care, which was like really helpful for shelves and just learning general surgery in general. So if you're interested in like a surgical subspecialty, Metro was really good for doing that. And I think the hours were like, not that it matters that much in surgery because the hours are going to be long anyway, but I think they were slightly better at Metro versus some of the other places.
Conflicting opinions.
Is there? I don't know, maybe, yeah. Maybe it's changed then. But overall, I learned a ton at Metro and liked the people I was working with for the most part. So I have mostly good things to say about Metro.
You want to add to your?
I was just going to say, like, the residents are the same. So, like, most of the general surgery services, like urology, they all rotate together. So it's really, I mean, you don't know who's going to be there when you're there, but that's something to keep in mind. So if someone says, like, oh, the residents at UH are awesome, like, they're the same people. So.
Patrick, go ahead.
So I did my surgery third-year rotation at the Cleveland Clinic, and then I did my surgery AI at UH. So I can kind of, looking back at them, I think everything's very team dependent, especially for surgery more than most, because you don't often interact directly with the attendings on either. You kind of go through your residents and then eventually the chief resident, and they have more interaction with the attending, at least in my experience. So that kind of can make or break an experience by itself, depending on who you're with resident-wise. But I would agree with, I think Kyle said it, where I've heard, I didn't do it at Metro, but I heard they have a little more options in choosing like a subspecialty for a couple weeks. At Cleveland Clinic, they assign you to a general surgery service, at least when I did this, and then they assigned you to a specialty service. So when I was there, I did acute care for a few weeks, and then I did vascular surgery for a few weeks. So if you are really interested in a subspecialty, you may have more flexibility not at the clinic. But otherwise, I'm trying to think of any big difference between the two. Maybe there's a few more fellows at the clinic compared to UH, but they're both very similar, and it all depends on kind of the residents and attendings you're with, whether it'll be a good or less good experience.
Yeah, I mean, I think most people would echo that, and Jamie, I'll get to you in 1 second. It's that a lot of you're going to have great experiences at all of your clerkships, but a lot of what you take away is going to be team dependent, because you'll have 9 out of 10 people who will say, oh wow, CCF was great for cardiology, for medicine, because it's part of their rotation, and you'll have that one person who says, well, my team was awful and I absolutely hated it. And if that's the only person you listen to, you're getting a very skewed perspective, which is kind of the whole point of this panel. Jamie, did you want to add something?
So everybody always forgets that the VA has surgery too.
They do.
And so I did surgery there, and when I signed up for it, there was sort of this rumor that anybody that goes to do their surgery rotation at the VA automatically doesn't want to do surgery, and it's not a very serious one. You don't learn anything, and that really definitely was not the case for me. I had a fantastic, really good learning experience there. In terms of interaction with residents versus attendings, the residents are the same residents as at Metro and at UH. See, they're all the same. But in terms of the attendings, you really do get, I think, a lot more contact with attendings at the VA just because of the size of the program over there. And there will be times when you would scrub into surgery without any other residents there. So it's just you and the attending and like the scrub tech. which is cool. There's less variety of things that you see there, but you also get to see a lot of the sort of bread and butter things and have more of a chance to do stuff, probably. And there's a lot of flexibility in terms of they gave us 2 weeks of elective that we could choose whatever we wanted to do. So people were able to do cardiothoracic and ortho if they were interested in those things. I got to do anesthesia, which was fabulous because there was a lot of medicine there, but they're also very hands-on. You work one-on-one with an attending, and you do lots of intubations and lots of procedures and things. So it was a really positive experience for me. Again, you're not going to see female patients there.
So keep that in mind if...
I just wanted to quickly touch on neurosurgery. I'm not sure if anyone's interested in that, but I did my neurology rotation at CCF, and you only have the opportunity to go to the, well, at least when it was, this was 2 years ago, but during my rotation, you only had like 1 day of neurosurgery for the whole month, whereas I think at the other sites you have the option to do several, like maybe 2 weeks. So I was okay with that. But if you're not okay with that, keep it in mind.
Yeah, so at UH neurosurgery, you can choose to do it for 2 weeks during your neuropsych rotation. If you have no interest in doing neurosurgery, I highly recommend that you pick everything else except for neurosurgery.
No.
Oh, okay.
So I have something to say about that. I think it's important to remember that if you are surgically minded, that you can incorporate some more, like, you know, hardcore surgery things into your other rotations. So, like, you know, at UH there's the opportunity on OBGYN to do gyn-onc, and I'm not certain if that's the case at other locations. You know, and then also at UH we have the good neurosurgery option for people on their neuro rotation. Additionally, you know, at UH, if you're more interested in, say, pediatrics, like you should be, when you go onto your surgery rotation, you can do a ped surgery as your general surgery team. You don't have to do adult surgery at all if you don't want to. And so that's something to keep in mind as well in terms of trying to tailor your rotations to fit your future goals, if you know what they are, if you are so lucky. So.
And I have like 2 points, just kind of, they pertain to surgery, but you can broaden them beyond this. One thing that I learned kind of later in third year was that if you really want to do something, you should just ask. So an example of that, so I initially was kind of discouraged I didn't get Metro for surgery, but then because I wanted to do trauma, and that's not really an option anywhere else. So actually from one of my elective rotations at UH, I asked if I could do trauma at Metro, and they said yes. So I did that. So if you want to do something that's not at one site, just like ask a question and it'll probably be granted. You might have to jump through a few hoops and maybe pay for parking one day, but it's worth it usually. The other thing was that, you know, kind of related to some other points, if you know, regardless of what field you want to go into, you can usually glean some useful information from whatever rotation you're on. So like, I really don't want to do surgery as a career. I want to do medicine, obviously, and I have a big interest in HEMONC. So I did the Lenhart service, which is the surgical oncology service at UH, and I can't tell you how much better I understand internal medicine's approach to cancer care just by understanding surgery's approach to cancer care. And so like that I kind of used that theme throughout my third year and really picked up a lot of useful things, I think, that will help me become a better internal medicine doctor and a better medical oncologist, just from picking up the kind of different information from different fields.
So let's go ahead and move on to another question. Go ahead, Sam. Oh, go ahead, Michelle.
You can do neurosurgery at Metro too, just to be clear.
Don't do it.
You
Go ahead,
can.
Sam.
I don't think so.
Oh, so the question was, should you, unanimous understanding too. The question was, if you want to do surgery at UH, should you consider doing, you know, sort of like its counterpart, medicine at UH, so you have an idea for the system?
I think there's just a sharp learning curve at the beginning of each clerkship. So, sure, I mean, the electronic medical record at UH is terrible. So maybe if you get used to it, it is. Honestly, it is. If you get used to it, maybe it will help. But really, I mean, every clerkship, you're kind of like running around trying to figure out what's going on because you have no idea. So
Yeah.
I'm not sure it's necessarily going to help.
I think most people probably agree to that sentiment. Okay. Go ahead, please.
Kind of going off that question, do you have any tips, like it's kind of a general thing, do you have any tips for our first rotation, like smoothing out the transition? And
Sure.
like a bumbling idiot?
So the question was, do we have any general advice for your first rotation so you don't look like a bumbling idiot?
I would say just don't worry about it so much. You're going to look like a bumbling idiot, and it's okay. We all did, and everyone did before us. And just try not to be stressed about it. I think that was really hard for me, is that I felt like I had to learn everything immediately, and there's no way to do that. So just calm down and learn what you can, and each day gets a little bit easier.
Any advice from down there? Yeah, Ron, go ahead.
So I started with surgery, which admittedly was very tough. I started on the general surgery service too, which was even harder because it was the first half at Metro where you start with gen surg, and some people started with like ED or consult, which is a little more laid back, I guess. But the main thing is that you need to know your patients well, and then second to that is to kind of know the science, but that's not as important, to be honest. You need to know your patients well and always kind of know why. So when you're presenting a patient and you say, oh, and they got an ultrasound back at this time which showed this, your attending's going to ask, why did they get an ultrasound? So you need to read notes, and you need to know things like what notes are good to read. You don't just go read old interns' progress notes. You read discharge summaries, and that gives you like a hospital course and stuff. So if just on your first day or two, if you can just find someone to kind of walk you through the computer system you're at, how to find relevant information, how to find scans and the radiologist impressions of the scans. You don't like read the readings, you read the impressions and stuff, and how to quickly filter relevant information. I think that is probably pretty helpful.
The one thing I'll add in addition to that is that sometimes you don't realize you're a bumbling fool until afterwards too. Like when I was on my surgery rotation, like we were supposed to get like consent from this patient. I went in and talked to the patient and got all the history and stuff. So I came out and I presented to the attending. The attending's like, no, this patient needs a doctor. And I was like, yes, the patient does need a doctor. He's got a hernia, he needs surgery. She's like, yeah, but no. He needs a doctor in order to get the consent, and I had I was like, it went way over my head for a second. But I think one of the things that kind of eases a transition into the third year rotations is your excitement for being on the wards, and excitement for this new experience. And gradually over time, you're going to get comfortable with being uncomfortable. But as long as you realize that like that pain is temporary, it'll last a minute, could last an hour, it might even last the whole year, but you get used to it. It's only temporary, and the pain gets replaced with like good feelings of like accomplishment that you've come out of it knowing a lot more, and are much better for it at the end. But bringing in that like, you know, that naivete almost really helps as well.
So everything that everybody just said is absolutely correct. I would just say the one thing that you absolutely can control, because no one's going to expect you to know as much as doctors do, but the one thing that you do have is your work ethic and your ability to at least seem interested and ask questions. So knowing, ask on the first day, like what's expected of you, what's important, what do I need to do, what's the expectation for me as a med student on this service? And usually they'll have a pretty good answer for you. If they don't have a good answer, then you got to figure it out as fast as you can. And then once you know what is expected of you, do that and then build on it and start asking to do more and asking to do more, and try and do things that you're scared of doing. Because yes, like rectal exams, those can be scary. And he mentioned that randomly, but my first day on call, I did a rectal exam and an IND, and I had never done either. I actually literally had to go on Google and look up how to do an IND. Incision and drainage. This lady came in with an inguinal abscess. Huh? You like my gesticulations there? But But no, you're not going to know as much as everybody else, but be okay with that. Ask questions and just work. And people appreciate that. They appreciate it a lot more than you think, actually.
Go ahead, Patrick.
I really didn't have it. They said what I was going to say. Just take comfort in knowing that they know you know nothing as a third year. I mean, you know something, but they know that you're new and that you're still learning how to even keep with the flow. Don't stress out about it.
Yeah, and I think in the end, like, I used to always get really stressed when I didn't know a question. I'd come home and I'd like dwell over like, how could I not known that, those kind of things. Like, the attending forgets like the second you leave. The second you like walk away from them, they have no idea. They don't remember you like missed a question. So in the end, like, don't harp on it, because I did that a lot and now I don't care so much anymore and I'm a lot happier for it.
Me too.
And so the other thing is also make sure that everyone around you kind of understands what a med student's role is. So Sarah and I were talking tonight about, you know, what's like the biggest reason like you get a certain grade. And so, you know, we figured that kind of the biggest issue was, you know, different people having a different understanding of what med students' roles are. And it's hard for you to understand that if you haven't talked to them, because everyone has a different understanding of that, right? So it's a good idea to get like everyone on your team, including like residents, interns, and whatnot, to have basically get on the same page. You know, like, what are the unwritten rules of this rotation? Like, should I be here at 5 a.m. pre-rounding, or should I just come for rounds at 8? Is it okay for me to eat lunch, or do I look like a slacker when I eat? Like, ask these things in tactful ways. And find out, you know, kind of what you need to do to succeed, and then do something nice that goes a little above and beyond that. Whether that's calling patients in family medicine, you know, offices, or whatever you got to do, you know.
Yeah, I completely agree, and I'm still working on this myself about right away asking, just very simply, what are your expectations for me? The times that I have done that have made it a lot better. I've had residents who are really stressed out themselves, so honestly, they want me to give them a little bit of space. And if you're able to sort of work with people and figure that out right away, the experience is better for everyone. The second piece of advice I would say is to act like you are an adult, because you are an adult and you'll get treated like one. I think only one time during my whole third year did I ever get like classically pimped by an attending, and I think that's kind of a rare experience, because I always acted as though like I was allowed to be there, and when there was an opportunity for like an educated question, I tried to ask it, and I didn't get in this situation where people thought they could sort of treat me like a child, because we're not children, even though we don't have a lot of knowledge. So I would say, really, this doesn't mean that you can like kind of be in control of every situation, but you know, be sure of yourself as best as you can.
Well, I've got two things. I think the one most universal thing that applies to any rotation is that you need to be able to do a good history and physical. And that's something that you can control now in terms of reviewing for getting ready for the wards. You're going to learn what they want you to learn while you're there, but in getting ready, you have to know how to take an HPI from a patient. And I'm sure you guys probably already do, but it's something that you definitely build on during the year on trying to learn what questions to ask, how to ask them, and how to do it efficiently in a way that's, you know, effective. So if that's, I mean, that would be something that I would, looking back, wish that I worked more on before going onto the wards, because then I was playing catch up early on. And then I think going along with that, I think you just need to be prepared to not always do it right and be okay with that, just like we were saying. And in regards to histories in particular, just get used to asking a patient if they have any medical problems, and they'll say nope, and then the attending will walk in and they'll say, oh yeah, I have diabetes, I have hypertension, I've got, you know, all these other things, and just be okay with the fact that you're going to screw up, or somebody's going to tell you something different that they tell the attending. It doesn't reflect poorly on you, and just do your thing and you'll do fine, really.
So we'll go to Kyle and then Ellen, and then we'll go back and ask some more questions.
So some rotations are different in terms of who like doles out your work to you and who gives you which patients to follow, and ones where you're kind of like you can pick and choose from a lot of different interns. It's important to kind of do whatever your senior tells you to do at all times. Like, never like say no to like a senior resident or whatever. But interns, like, learn to kind of say yes or no to some of their task because they're not, like, especially at the beginning of the year, if you have a rotation in July or August, whatever, it's going to be very hard working with some of the interns who are very new as well. And they don't necessarily know like your role there or know that you don't know anything. So try to keep it simple with your earliest rotations. Take really bread and butter patients that have a simple problem, and don't stress yourself out too much with really complicated patients, because not knowing hardly anything about a really complicated patient is going to make you look a lot worse than knowing slightly something about a not so complicated patient. So try to find the sort of simple bread and butter cases of the specialty you're working in, and don't let interns kind of push off too much work on you when you're new.
I just want to say that one of your best assets is your other medical students. I think before I started, I heard a lot of talk about gunners and about people undercutting other students, and I never, ever felt like that was the case. I thought it was so helpful to have another medical student with me. When you wanted to ask a stupid question about what does that abbreviation stand for, you could just ask them instead of asking, your attending. Or if you rotated to a new hospital, maybe one of the medical students had already been there and could say, oh, here's how you find this, imaging study, or this is how you do this, or this is where the bathroom is, something as simple as that. So definitely, or if there's an older med student, they can offer a lot of perspective on their experience, and maybe they're on an AI and they're trying to go into the specialty and they know a lot about it and they're willing to talk to you when everyone's ignoring you both.
A lot of this stuff, this isn't just like a screen. There's actually a PowerPoint presentation after this. So some of this stuff will be covered as well. Go ahead, Julia.
On the topic of asking questions or asking to be shown to do something, I mean, it may depend on how stressed out your resident is, your attending, but is there a good way to sort of, if you don't know how to do something, or if you don't understand a certain process, how to know whether or not you're being annoying?
So the question is, how do you tactfully ask a question without being annoying? Go ahead, Aaron. You want to pass the mic down there?
So, without being annoying. So the best way that I found was just to say, I don't know, whenever you have a chance, can we go over how you do X? Or like if it's a procedure or something like that. Or later on when we have a minute, can you tell me why we did this, X, Y, or Z? So you're asking about the rationale behind something without saying, I don't know what's going on. But also you're giving them the option to explain it to you when you have that time. So you kind of get on their mental agenda, and when you bring it up later, it's not like you're interrupting. If that makes sense.
Yeah, and I think another good way to look at it is just be aware of the situation that you're in, and don't, because we always get really excited. We have these questions. You're like, finally, I have an actually good question that doesn't make me sound dumb, and the patient's crashing in the OR. So it's just, I've seen it happen before, and it's just be mindful of what's going on around you. If you have 30 patients to round on in an hour, which happens a lot on peds, don't ask the question then. A lot of times the attending will be glad to come back later. So say when you have a chance, I'd really like to talk about this patient, and they'll come back and they'll discuss it, but just be mindful of what's going on around you.
Michelle?
Yeah, I agree. I was going to say the same thing. Just use common sense. You'll get a feel for how things work, I think, pretty quickly. But then also if you're going to do a procedure and you're already in the patient's room and the resident's handing you the tools to do the procedure, just don't ask then. Just kind of be cool about it, because that happens a lot. I don't know. They won't ask you to do it if they don't feel comfortable with you doing it, even if you're not solid on what you're doing.
Go ahead, Miles.
So in the same vein, if you don't feel comfortable doing a procedure, don't do it. So a couple weeks ago, I was in the ED, and I had a kid who was screaming his head off, and we had actually given him some sedation, and he was still screaming his head off. And I had to do a scalp lac right above his eye, and he was all over the place, and I was gonna poke him in the eye, I'm sure of it. So I looked at my resident, I was like, I don't feel comfortable doing this. Would you be able to do this? You have much more experience. And he did it. And we handled it tactfully without making either of us look like idiots. And, while making sure that the patient care wasn't suffering from my learning experience, or his eye wasn't gone from my learning experience.
That's good advice. Yeah. Sarah?
I think I'd agree with what's been said about find the right time to ask the question. Don't if you have a question right away. carry around a little like Moleskine book in your white coat and write down questions, and you can look them up or ask. People like to answer questions. But as far as like stupid, silly questions go, I think it's really helpful to, when you're rounding in the morning, to find your patient's nurse and like ask the nurse questions, what happened overnight and stuff, because that's often hard to find in the computer when you're not familiar with the record and stuff. So find the right people to ask the right questions. Don't like track down the resident who's rounding on 6 patients in the morning, questions about your patient kind of thing. So.
And ask the questions that you can't find easily. Like, if it's something like, what is X if you have Y? That's fine. Ask just really quickly. But like, if it's something that you can find easily on whatever page of a textbook that you know of, don't ask about it. Like, if it's something very complex that you don't understand the interconnectedness of something, ask about that. And it makes you look smarter because you understand that interconnectedness and you're asking about it.
It also shows effort too, which goes back to whatever I said before. It also goes towards showing effort. If you have read something and then say, "Oh, I still don't get it," I mean, at least you could say that I read this in book Y, and could you help me out with it? It goes back to demonstrating effort and interest.
Yeah,
Yeah,
and
I
Rod
was
mentioned.
just-
Oh, sorry.
Go ahead. I was just going to say that just remember that the only people that you are allowed to learn from are not just necessarily the residents that you're working with. Like, for example, I'm in the ED right now, and they sort of consulted ortho to do something with someone's fractured finger. And so I wanted to, see how to splint it and see how they decided to close it and see what their decision-making was. And so I kind of found that resident and followed him around and learned from it. So there's, a lot of people, including nurses, other consultants that come in through your service that might be willing to teach you more honestly than your team. So just be open to learn from whoever might be there, and you can really find some great opportunities.
So we'll go Steph and then down to Emily, and then we'll go back for questions.
So Ron just mentioned nurses really quickly, and I just want to say how helpful nurses, social workers, NPs, anyone who is involved with your patient, I think it serves you well to actually get to know them and know who your patient's nurses are, because in the end, they are going to be the most helpful at times when you really don't know what to do because the residents are running around with their heads cut off and you don't know what to do. Find the nurse, find the NP, find the social worker, and also take ownership in your patients and understand that you can help the social worker with your patient. You can help the nurse with your patient if that's the time that you have in the afternoon, because in the end, that usually will get back to the resident, it'll get back to the attending that, wow, this medical student was really helpful, whether or not it was with specific medical things or social work, but they helped out, with the whole patient. So.
Yeah, and I just wanted to say with regard to effort, you don't have to put a whole lot of thought into questions. You don't have to really think, is this a good question or is this a stupid question and blah, blah, blah. It's really just the way you phrase it. So if you have a patient with a hemoglobin of 10 and you don't know what that means, if you just go, oh, what does that mean? You'll look kind of stupid, right? But if you at least take a shot at it and go, oh, is that low? Does that indicate anemia or something? Then you've at least met the resident or the attending halfway. At least shows that you're thinking through something. So don't worry about how valid your question is. Just think a little bit about how you ask it.
So we'll go back to the floor for some more questions. Lee?
How many letters of recommendation do you need?
12. I'm just kidding.
Yeah, how many, who should you be trying to get those from, and, do they have to be from just your specialty or, other things?
So the question was, how many letters of recommendation should you be trying to acquire, and from whom should they sort of come from? So we'll just get responses from two panelists because it's already 7 o'clock. And
Okay, I'll respond since I'm holding the mic. So I did ortho, but I would say, I think this is true for other things. A lot of places tell you on their websites in their application requirements how many letters they want and also who they want them from. So that being, for me, ortho, some places said we need 3 letters, they all have to be from an orthopedist. We need 2 letters, one has to be from an ortho chairman. One can be from anybody. We need 2 letters, one has to be from ortho, the other one can be from any surgical subspecialty. So you really have to keep an eye out on what specific places that you're applying to match into what they want. That being said, I mean, I've sat down with Dr. Marks, who's the chairman of the ortho here, and he said we want good letters. It doesn't necessarily matter where they are, and I think that's kind of the attitude, except for urology, apparently. So for instance, I had 7 letters of recommendation, but that's only because I kind of went, as I went through third year, I was looking for people who I thought would write me a good letter of recommendation. So I was asking as I went through. So I asked during internal medicine, and I asked during family medicine. So I have letters from those people, and I'm going into ortho, which some places would look at and laugh at me if I sent them in, and other places are looking for those kind of, like, they just want dynamite letters. I have a letter from Dr. Bruzik, who probably worked with you in Block 2. So he has nothing to do with orthopedics, but except for he has bones and joints and whatnot. But you know, if you can get a good letter from somebody, ask them, even if you're not sure that you're ever going to use it. I would do that, and then write them a good letter. You know, write them a thank you letter and let them know how much it means to you.
That's good.
You keep them, and then they get uploaded electronically when you're applying, and you'll learn more about that.
Good question. Anyone? Any other questions?
We were going to do 2 and then...
Oh, I'm sorry. That's right. Jamie, do you want to take this one down there?
That being said, you're only allowed to send a maximum of 4 letters to any given program. So you might get 12 letters, but a program's only going to get 4 of them. So really, you only have to worry about getting 4 in the end.
You can pick and choose, like, you know, which letters you do want to send. If you want to send like an auxiliary letter, you can do that.
And if you're going into a specialty that's not surgery, people really care about getting letters from people who know you and know your work and know that you are a good person and competent. So it's not about what specialty, what hospital, what name, if it's the chairman or not. It's really, you know, these people can really speak to you and give good examples and talk like they know you.
And I'm sure this has come up on a lot of your interviews that when you're interviewing with the program director or someone at the faculty, they'll mention, oh, you know, so-and-so said these really nice things about you. So I think it does reflect on the quality of the letter and how well that letter writer knows you. Because, yeah, you could get a letter from, you know, the CEO of university hospitals, but if they only write like 3 lines and it's very generic, it's not going to carry any weight.
I just wanted to touch on really quickly programs' websites. So I think they're a great resource, but they're not always totally accurate. So after my application was in for like a long time, like someone mentioned like a chairman's letter, and I realized that there were like multiple PEDS programs that their websites asked for a chairman's letter. I have no idea who the chairman of PEDS is, and it did not make a difference in my interview season, so that just wasn't really accurate.
Okay, back to the floor for questions. Go ahead.
So following up on the AI letters, so do you still ask them as you go along if you don't know what specialty you want to go into? Because wouldn't they mention in the letter like, oh, this candidate would be great for X, Y, and Z, but if you don't know what you want to go into, would it be better to ask later?
So she asked, is it better to, do you get the letters right away when you're rotating through people, or is it better to wait till later and then ask? So the way I worked it, so I did surgery first with Ellen, and then I did internal medicine next. So I had almost a year and a half before I had to turn in an application after doing that rotation. And and they know that when you're asking for a letter of recommendation. And they'll say, well, let me know as it gets closer, you know, what you're thinking of doing and when you need it and all that stuff. And they'll write it for what you're trying to do. And yeah, as long as you think they're going to be able to speak well about you and you think they know you and can write a good letter, then ask them, and then they'll write it when you need it. They don't write it to you right then and then give it to you. Because, yeah, they need to know what you're trying to do.
Emily? Do you want to add to that?
I was just going to say, I wouldn't worry about letters right now. I didn't think about them until I was doing my AIs, and I got more than enough. And yeah, there are more competitive specialties out there for emergency, so I don't know, maybe there's other scenarios, but just don't worry. Focus on boards, focus on third year, just work hard, be interested, and it'll come. You'll have plenty of time to stress out about that stuff later.
Any other questions from you guys? Yes, please.
There's one question. I was interested in hearing, like, how many of you guys stuck with what you thought you wanted to do going into third year?
So the question was, how many of the panelists ended up going into what they thought they wanted to go into starting third year?
I can start with that. Oh, are we?
We're just supposed to raise up hands. Yes. Okay, so over half. Yeah, you're like 55%. Did somebody want to speak to that, Ellen?
Well, I just want to say that I didn't have any idea what I wanted to do, and which was kind of nice actually, because then I really liked all my rotations, because I was like, well, maybe I'll be this or maybe I'll do that. But I had no idea that I'd come out of med school being a gynecologist, but I just absolutely loved my rotation. So, you know, if you're one of those people that has no idea what you're gonna do, you'll find it, you'll feel it. And some people were, you know, I felt sorry for some of my colleagues that were torn between 2 specialties during application season, writing 2 personal statements. But even now, I feel that everyone is really sure. So.
Any other questions? Lee?
Yeah, there was something on the curricular affairs thing about medical student duty hours or work hours. Is that like?
We're supposed to follow the same hours that residents follow. They're not very, no one keeps track.
It's really dependent on your team. Like my chief for surgery was also an administrative chief, which I guess didn't matter because the other administrative chief made people do like a 24-hour call. But my chief was very strict and would only let me stay till like 9 p.m. when I was doing my calls, and would make the resident text her that I left and make sure that I didn't work over 16 hours a day. But that's like, I didn't hear that a lot.
So just to recap, the question was regarding medical student work hours and how exactly that comes into play.
So I have something to say about that. Just in general, I think it's good practice to leave when somebody tells you to leave. I think that's, you know, everybody's really excited about being on the wards and wants to look like a hard worker and stuff. But people, when they say, okay, you can go home, just go home. You won't ever break the duty hours. You really won't, because maybe you guys have, but I never have. And so I always go home, and it's good to do. You know, take time for yourself 3rd year, and you'll be fine. Don't worry about it.
Miles?
So I broke them twice because there were residents that expected me to do like a 26-hour shift. And so if anyone expects you to do that, tell someone. It was like very early in my 3rd year, and I was like afraid to like mess up the balance or whatever. But like I ended up just like being a zombie for a couple days. So like tell someone if someone's doing that kind of stuff to you, because like you shouldn't have to do that. You should do no longer than 16 hours, and you usually don't do anything near 16 hours anyway.
Emily, go ahead, Ron.
So I don't know if this has changed or if it was an oversight or anything, but at Metro you do at least one 30-hour shift, because you generally work from like 5 a.m. to say like 8 p.m. or whatever. But when you're at Metro, which is different from every other place, you take 3 trauma calls, which are 12-hour shifts, and you will take one that's Friday night from 6 p.m. to 6 a.m. And then your team may ask you to come around Saturday morning also. So I worked like a 30-something hour shift, and it's not that bad. You can like ditch and sleep for a bit. But I guess you could kind of like tell your team you have duty hours, but it's kind of like your comfort level and stuff. But you can always stay at the hospital after and find a place to sleep before you go home. I don't know. I don't think other places have you do 30-hour shifts, though. I think that's Metro surgery specific. What's that?
There's 24-hour call at UH that I took, and my resident was like, okay, we have a case. Are you staying? And I said no. And I went home.
All right, we'll just go back to the floor for any more questions. So the question is, what does it mean when you're on call? Emily, do you want to field this one?
Just want to say, usually call means you're staying overnight or you're staying after hours, and I personally love the hospital at night. You don't necessarily have to be shy about taking call or 30-hour call, 24-hour call, whatever, because the hospital's really fun. It's usually you and the resident and nobody else, and the only things that happen are things that are important, like all the daytime stuff, notes and rounding, and none of that matters. So it's just the exciting stuff, and you get a lot of one-on-one teaching time, and I liked all my calls, even though I broke duty hours constantly. I enjoyed it. So,
Michelle, go ahead.
Yeah, I was just gonna, oh, whoa, that's really loud. So night float is something you'll do for OBGYN, and that's like call, but you're kind of doing call all week. And that's like one of the best experiences you'll have because it's such a small team. So you're just able to do so much. So take advantage of call, especially if you're comfortable. Like don't go over duty hours intentionally, but it's just great because you'll get so much more hands-on experience.
more questions? Yeah. Okay, well, if there are no more questions, I'd like to thank all of our panelists for joining. I don't think we'll specifically have time to get to the step 1 questions, but I'm gonna blow through this PowerPoint really, really fast for you guys. And maybe if there's a little bit of time at the end, if there are people who stick around, panelists, if they have questions for you, or you can go home. Okay, all right. Yes, apparently there's a free giveaway, 1 ticket each, please. So at the end, if you'd like to take a, what is it for a Kaplan course?
Some Kaplan books, I have 14, I'll give them away, I'll just big tickets.
There are some Kaplan books. All right, thank you guys very much. Okay, so this is a PowerPoint that I created for you guys, Success in the Wards. Basically just gonna reiterate a lot of what was already said, but this will be emailed out to you as a PDF. So the first part is professionalism. So I'm going to pick on someone who I've had an IQ before, because those are the only people whose names I know. So I'm going to pick on Brian. This one seat over there. What do you think professionalism is, Brian? Acting like an adult, not a child. So I would absolutely agree with that, because, I mean, how many of you are younger than 18? None of you. How many of you are over the age of 21? Probably all of you. So you're also coming into a professional environment where the expectations are very, very high. You can't go into the hospital and act a fool. Remember that. No acting a fool. So this kind of comes to your general appearance as a professional. So gentlemen, you want to keep yourself either clean shaven or with your facial hair well groomed. So please don't ever look like this guy. Does anyone know who that is? Joaquin Phoenix. But on the other hand, if you look like this fine gentleman who has since left our graces, that's a very nice beard. Well groomed, well trimmed, that's fine. Also, ladies, try to keep your hair length sort of in check. Like if your hair is this long, that's not okay. Nobody wants to see that. So again, hair, that's personal appearance, that's kind of up to you, but in general, you may want to avoid things like faux hawks, actual mohawks, mullets, pink, purple, blue, aquamarine, and teal. So just, you guys all have very beautiful hair. You don't need to be dyeing it tie-dye. Now, as far as your white coats, what do you think is the biggest complaint about white coats from attendings and residents? They're dirty. How many of you have spilled coffee on your white coat? How many of you have dropped your white coat on the floor only to pick it up and be like, oh, there's a giant stain on it. Oh, that's okay. Yeah. And how many of you have pets who like to sit on your white coat and everything you own is covered in hair? I do. This is actually the only hair-free shirt I have right now because my wonderful fiance used up all of the sheets in the lint roller. So please, please, please keep your white coat clean. Additionally, the other thing is it tells people who you are, and it's kind of a safety net because people will see you dressed up and they'll see you have a short white coat and they'll be like, medical student, doesn't know anything, won't ask them to save this person's life. That's good. That is definitely in your favor because the last thing you want to be you don't want to be pulled in to run a code and be like, I have no idea what is going on. So it tells people who you are. It's also very handy because there's a couple of pockets in it, and even though they're like burlap sacks, it's all you have. So you can complain about it if you want, but keep it clean and wear it. Stethoscopes, snacks for when you're on your surgery rotations, very, very important because your scrubs only have so many pockets. So I would just bulk up with Lorna Doones and Oreo cookies and look like the Marshmallow Man walking around, but I was never hungry while everybody else was starving. So I would just munch in between cases. Like I said, reflex hammers, cheat sheets. So one thing you can do is either you can wash your white coat every week or every 2 weeks, or just go to the admissions office and buy one. I ended up having 5 because I was apparently I don't do laundry that often. And as far as the attire, again, this goes back to being a professional. You should not be rolling in to your clerkships in sweatpants. Well, we'll just run the list. So ladies, avoid the following: low-cut shirts, not professional. Cropped pants, blue jeans, and short skirts. I shouldn't even have to mention that. Extra high heels. This is more so just for your own safety because a lot of times when you're rounding, you'll be walking a lot and you'll be taking the stairs. So the last thing you want to do is like twist your ankle taking the stairs. So that's me looking out for you. Open-toed shoes. This is also for personal safety. You can absolutely wear open-toed pumps, but pray tell if something falls on them, like a scalpel, like if you're in the ED, that's going to be an incident report, and nobody's happy about that. Lots of bling. Don't do that. T-shirts. No T-shirts. Polos, shirts without a tie. Now, this is a little controversial because when you go to a site, just take a look around and see what the dress code is. If like all the residents are rocking like the top button open and you can see a little bit of their white shirt and no one's wearing a tie, that's cool. You can do that. If everyone is dressed up to the nines in a three-piece suit, you should probably do that as well because you don't want to be like the weird person who's kind of sticking out a little bit. I don't know anything about women's fashion, but you guys always dress pretty well anyway, so just use your better judgment. I wish Steph was here to speak on behalf of that, but I don't really know anything about that. So no sneakers, no tennis shoes, no boat shoes. Also, for your shoes, like we get a lot of snow and a lot of salt and a lot of crud. Make sure that they're clean because while it's like, well, what does it really matter what I look like? It matters because I guarantee you the moment you step in and you're a part of a team, every single person is judging you. Whether that's a good thing, whether that's a bad thing, it happens. So do your best, look the part, make life a little bit easier for you. I was on neurology with a fourth-year AI who had his tie loosened like that and had the top button undone on rotations, and the chairman of the department absolutely destroyed him for being, unbecoming of a professional doctor for like 10 minutes in front of everyone, in front of a patient's room with the door wide open. So you don't want to be that person because that person becomes infamous in your class. I won't tell you. I won't tell you. So again, why does it matter what I look like? This comes back to professionalism. You are part of a team. Some of your attendings will be very old school. So like I said, if they catch you with the loose tie knot and your top button undone, you will hear about it. Again, check to make sure your shoes don't have any marks, dried salt, mud. Okay. Now this is really what's important, is how not to succeed. Do not steal your fellow med students' patience. It is very poor form when you're rounding in the morning. Let's say Lee is presenting, Miss Deskin. She's a 92-year-old woman who came to the ED with complaint of diffuse abdominal pain. CT scan revealed copious free air anterior to the diaphragm. I think she most likely has a gastric perforation. And then let's say that Rebecca is like, oh, well, actually, Lee, I read the radiologist report and it said da-da-da-da-da. Like, that's not okay. That's very poor form, and you will be shunned. Not you specifically, Rebecca, but that's poor form. Like, you guys should be trying to support each other, trying to help each other out. So don't steal your fellow students' patience. Don't try to show off your knowledge. One thing you really shouldn't try to do is I'm going to use kind of a pseudo-bad word, is piss off your intern by trying to show them that you know more than they do, because you don't. Exactly. Or your senior, or your attending, because they will make your life miserable. Like all the times when you want to ask like a question, be like, oh, hey, what does this hemoglobin mean? They're not going to answer it. They're going to lose all respect for you. So, be very, very careful how you try to show off your knowledge. And there is a tactful way to do this. Again, discussing inappropriate things on service. Just like when we have guests who visit our IQ rooms, you don't want to be talking about all the things you did over the weekend. Nobody wants to hear that, at least nobody in your team. If it's like if you absolutely unequivocally have to share it because you had such a fantastic time, find the appropriate time and place to do that. Don't interrupt your attendings when they're trying to make a teaching point. They're there trying to teach you. Take advantage of it, because not every single attending is going to give you the time of day. So when they do, listen, whip out your notebook, and write down what they're saying, because most likely they're actually trying to instill some knowledge in you. It's not because they like to hear themselves talk, although some people do. And being receptive to feedback is really, really crucial. One of the best things you can do is take the feedback that you're given on a daily basis and regularly ask for feedback. Be like, hey, how do you think I did today? How were my presentations? What would you like me to improve on? And then try to implement those changes in 24 hours. Because if somebody gives you feedback and you don't do it, it's like you really didn't care about their opinion. Alternatively, if you never ask for feedback, you won't know what the benchmark is and how you can improve. And don't make excuses. You know, like if you did something wrong, you did something wrong. If you forgot to ask a question, that's okay. Don't be late. And don't lie. Again, don't make up information about your patients. If this person does not have a history of gastric ulcer disease and you make that up because you think that it adds to the clinical presentation, or if your attending says, oh, you know, who else can I pick on in here? Parita, does Miss So-and-so, you know, what doses of metformin does she take? And you're like, oh, I think she takes 1,250 milligrams. And it turns out that she doesn't even have diabetes. Like, that's just not going to look well for you. So like I said, it's totally all right not to know something, completely separate to lie. So how to do well. As a lot of these people said, you know, take control of your own education. Read, 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 read. Every patient you have, read up on them. Every night, read up on them. When you have free time, what should you be doing? Either taking a nap or you should be reading. One of the two. Find your bread and butter patients, asthma, COPD, abdominal pain, and read. Find your extremely rare patients and read. So when you have someone who comes in with chronic granulomatous disease, read about them. Or like hereditary angioedema, read about them. You should be reading every... I think you guys are getting the theme here, right? Okay. Again, be receptive to feedback and ask for feedback on a regular basis. If you receive constructive criticism, like I said, try to implement those changes within 24 hours because it shows your team that you care. Be confident. It's okay to be wrong. So when you're giving your presentations, you know, plant your flag. Be like, I think this is what's going on because of X, Y, and Z. I mean, it's just like your SNAPS presentations. Like, here's my differential diagnosis. I think the patient has this because of this and this. You could be totally 180 degrees completely wrong, but at least be able to justify why you think what it is. Like, you know, don't be wishy-washy. At the same time, if you're wrong, like, don't try to argue it. Like, if your attending says, no, I'm sorry, like, they don't have a microcytic anemia, and be like, well, all of their lab values point to this, and they'd be like, well, they don't, here's a blood smear. You know, then you kind of look like a three-letter word that starts with an A. Like I said, stick your proverbial flag in the ground in your assessments. It's okay to be wrong. And this is where practicing with residents will really, really be helpful. So I know when I started, I would practice every single one of my morning presentations with the residents, and you would not believe how much more information they know than you do. And when you get in good with your resident and they pass that information on to you, you look like a boss. Point in case, I had a patient on pediatric who had an empyema, and they did an ultrasound, and the resident said, oh, do you know why they did an ultrasound? And I said, I have no idea. And they said, oh, to look for loculated effusions. And guess what my attending asked me on rounds? So, Guyon, why do you think they did an ultrasound? And I said, oh, well, because they wanted to look for loculated effusions. Then I was like, bam! 10 points. And I did buy that resident a cup of coffee. Okay. Know your patients inside and out. You are, in theory, responsible for their care. So you should know every single nuance and every single detail about that patient. Now, do you need to share every single nuance and every single detail with that patient, with your attending? Probably not. Your attending might not care like what time Miss So-and-so's bowel movement was. But if you know that and they ask, then you'll have the information. Hey, Nita. Like I said, you don't need to provide every detail, but you should know every detail. So presentations and notes. Most of your notes will either be a SOAP note or an admission note, occasionally a discharge note. Admission notes, chief complaint, HPI, PMH, meds, family history, social history. SOAP notes are sort of daily progress notes. So how did the patient do during the previous day and night? Anytime there's a change in your patient, like a blood culture comes back, they go down for radiology, there's an incident, they have a code, they have a heart attack on the floor, you should document that and write a note. So what is the chief complaint? This is what they say, quote, in their own words. So it's okay to absolutely leave this in. You know, if you feel the need to extrapolate a little bit, i.e. a lot, because you'll have to, you'll do this in the HPI. So, yes, please. Oh, hi.
So when you're saying to write a note at anything that happens, how does that work with like the EMR? Like, don't you can't write your own note?
So you can. So in a lot of the EMRs, you can write your own note, and it might be an incident note versus a progress note or an admission note. But usually what happens is you'll have to put in a resident or an attending to co-sign that for you. And really it's, okay, I'm gonna be honest, like no one really reads your note, but sometimes they do. So it's good to have excellent information. And you can help your residents out a lot because you have to write a note on the patient, they have to write a note on the patient, and if you write good notes, they'll be able to glean a lot of the information off. So also don't make your residents look bad by lying in your note because they're the ones that are going to be held accountable by the attending, and then that resident is going to hold you accountable.
So you can just add their name onto it.
Yep. Yeah, it's just called an attestation. Just attest them on. So what are some simple ways of asking a patient what their chief complaint is? Anyone? What brings you in today? Excellent. What else? That's good enough. Tell me more about it. Good. So HPI, this is what Mike Mont was getting at. This is one of the best ways and one of the best things you can do as a medical student is learning how to take a good history. So you guys all know your OP, QRST, pain, duration, radiation, onset, what makes it better, what makes it worse, what medications have you tried, et cetera, et cetera, et cetera. So this is where you can really paint a picture and show off your history taking for your attendings. I'm going to skip all this stuff. Review of systems. Use your Maxwells. How many of you guys have a Maxwell? Okay. Make this a goal before you start your third year. Everyone get a Maxwell. Because how many of you actually know all the dermatomes? I don't know all the dermatomes. Maxwell has a great sheet. Ron, do you know all the dermatomes? If you have your Maxwells. Good. Maxwells. Physical exam. Physical exam starts when you walk into the room. I tell the people in my IQ group this all the time, like have a system for doing your physical exam. Because if someone comes in with abdominal pain and you forget to do an abdominal exam, you kind of look a little bit like a goof. So if you do your physical exam the same way every time, you're going to be fine. These are labs. And all this stuff is going to be given to you in a PDF, so I'm really not going to go through it too much. But assessment and plan, this is what everyone wants to hear because it's what do you think is going on with the patient. So like I said, plant your flag, give your differential, and just take it from there. So things you can do to really set yourself up here for success is volunteer to take on the workload. If an interesting patient comes by, like you have a patient with chronic granulomatous disease, do a PowerPoint presentation on it. Do some extra reading and share your knowledge with the group because everyone's going to benefit from it. Or like eosinophilic esophagitis. Those are ways that you can share your knowledge without trying to look like a quote-unquote gunner because nobody likes that person. No one likes a person who tries to dominate rounds and share all of their knowledge and make all the other med students look bad. At the end of the day, yeah, everyone is trying to get honors, especially Michelle. Everyone's trying to get honors. But you know what? Like, it's okay if you don't get honors, but I know you're all type A personalities. Everybody wants honors. And there is room for every single person to get honors on a rotation. But you don't want to do it at the expense of your colleagues. Because, like I said, if you do that, that is definitely something that residents will pick up on. They'll report that to the attendings, and when you send feedback to the attendings who ultimately evaluate you, it's going to show up on your feedback. Okay? Are there any questions? Go ahead.
Doing the reading thing, do they give us suggested reading or anything like that?
So I will say that once you are in the third year clerkship, your suggested reading list, courtesy of the IQ facilitators, is out the window. So sources that a lot of people like, up to date. Don't use Wikipedia. Don't do it. It's okay for IQ, but not really. Oh, I'm sorry. The question was, are we provided with a list of recommended resources? The answer is no. So up to date is a great source. Just go to Dr. Google if you guys are familiar with that search engine. It's just Google, but okay, that's a bad joke. Lee did not think that was funny. Thanks. Pity laughter. That's good. Okay. No, but up to date is very reliable. Like Access Medicine, Harrison's, all your basic science texts are going to be very useful. That's a good question. Any other questions? Please.
How much time do you generally get with the patient to work them up?
Yeah, so that's actually the beauty of being a med student is you're really not going to take on, sorry, Paul. The question was, as a medical student, how much time do you get with your patients? So you're really only going to take on 2, maybe 3. If you're super awesome like Michelle, you might take on 4 patients. But residents have 8 to 10 patients. So you're going to have all the time in the world to listen to this person, form a relationship with them, and really get the nitty-gritty stuff, which is why medical students are so integral to a team. Because residents, they're in, they're out, 5 minutes, they got to go see the next person. But if you only have 2 patients and you have 30 minutes to see them in the morning, that's 15 minutes each. There's a lot that you can get. So medical students really do add a lot to the team. So don't take your role lightly. I mean, you're a very, very important cog in the wheel. Go ahead.
I have a question about just taking notes.
Sure.
You're talking to the patient and things like that. I've seen a lot of people use different things, maybe note cards or
Yeah. Yeah, like whatever works for you. If you like, no one's going to be offended that you're not like making. I'm really bad at this. The question was, because I've already forgotten it. Oh, right. When you're talking to a patient, is there a better modality for sort of like taking notes or note cards or Moleskine books? And the answer, in my opinion, is no, not really. Just whatever works for you. Again, just be as thorough as possible. Was there a question over here? Yeah, Keith.
People have mentioned a few times like giving a PowerPoint presentation or something to kind of show off knowledge. Is there like time allotted for that, or how would you go about it?
So the question was, is there time allotted to show off your knowledge via PowerPoint presentation? Yes, usually. Usually the busiest time is during morning rounds, but then in the afternoon, like virtually nothing happens unless you're on surgery, in which case like there's cases and whatnot. But a lot of the non-surgical areas, there's plenty of time, and you can tell you're attending ahead of time. It's like, I read up on eosinophilic esophagitis, and I read this paper. Would you mind if I just spoke about it? And they're like, oh, sure, we'd love to. Unless you're with Bob Salata, who's the chair of infectious disease, in which case he knows everything that you could ever find, but like 24 hours in advance. So if any of you guys have any interest in infectious disease or medicine, he is a genius and a great person to rotate with. And I hope he's watching this. I'm just kidding. He's not watching this. Any other questions? No? Oh, yes, go ahead.
So I'm always wondering, in the internal medicine service, there's nothing happening in the afternoon.
What do people do? No, so the question was, like, if there's nothing happening in the afternoons on the internal medicine service, what do people do? And I'm exaggerating. There's a lot that's going on. You have new admissions. You have new patients who are coming to the floor. That's a chance for you to practice your physical exam and your admission notes. There are consults for you to see. There are procedures that need to be done. Plenty of rectal exams to go around if you need more pressure and whatnot. No, you guys all did your thing, at the free clinic where the guy's like, and even more pressure. Didn't any of you have that? Okay. Apparently that scarred some of you. So there's plenty to do, but there's also a lot of downtime for you to do your reading, for you to do your questions, for you to study for the shelf exam. There's plenty of time to do everything. And I'm going to throw this out there. When I was on surgery, I played tennis like 5 times a week. So, it's not like the most time demanding rotation, I thought, but it was actually the rotation I did the least work on. So, go figure. I'm going into general surgery.
Where did you do it?
At UH, but that was the exception and probably not the norm. Any other questions? No. Okay. Well, good luck to all of you guys. And if you can send out my email address if you guys want to email, or I can provide you the email for any of the panelists if you have specific questions for them or which specialty they're going into. Good luck to all of you guys, and hopefully, we'll see you in the hospital. Oh, I'm sorry, real quick.
Sorry, I won't take up a straight time. My name's Anita. I'm a 4th year. Thanks. And yeah. I'm really glad that Guy did that presentation because it's a really good heads up for what you're supposed to be doing as 3rd and 4th years. But I just want to let you know that our class is starting a YouTube channel, and it's basically 5-minute videos on things to do with being a clinical medical student. So this has to do with basic knowledge stuff like ECGs, and also with how to get by stuff like pre-rounding or how to not mess up in the OR. So I'm going to be sending out an email to your class probably this weekend, kind of giving you links to all the videos. And I'm also inviting you guys to send us topics that you want added to the subscription channel. So if you guys have any lingering questions about what's supposed to be done or how to do things or not to do things, just email me. I'm Anita at case.edu. And KCK is also going to start looking for 2nd and 3rd years who want to help carry this project on and make it even bigger than it is now. So if you're interested in that, please email me also. All right, thanks. Have a good evening.